I'm Sabine Oertelt-Prigione, and I'm a professor of sex and gender sensitive medicine at the Radboud University in the Netherlands and at Bielefeld University in Germany. I've been doing this work for about 15 to 20 years. I'm a physician by training. I did some years in basic research only to realize that there's people who do that much better than me. I finished my clinical training and then moved on to studying public health for a while. And eventually, I also did a training as an organizational consultant. All of that to try to capture the breadth of what sex and gender can mean for healthcare. Although during the process, I didn't know that I would end up moving all these pieces together. And to do that, I've been living and studying and working in 5 different countries. So the process has also been very enriching on a personal level, and possibly that reflects also in the way I look at this and in the wish to work in interdisciplinary teams. Thank you very much for the invitation to participate in this, and I'm gonna try to give you a brief overview of what sex and gender sensitive healthcare is, what sex and gender mean towards healthcare, and most importantly, what the risks are in not considering it. So that might be something quite relevant to your design endeavors and to developing use. Well, in very simple terms, basically what happened with the discovery of sex and gender in healthcare was that we went from realizing that there was a human body that pretty much looked like this, to realizing that there were at least two, if not more, human bodies, and they don't all look the same. And so that was quite the discovery, and which sounds strange looking at it from outside. But in fact, we tended to really resort to one model, and realizing that this model might not fit for everybody was quite a revolution in the healthcare field. So the way we approached this was, okay, what do we do now? And the first reaction was this. So basically, the approach was everything that lies under this bikini had to be investigated separately. And everything that was not covered by this bikini could pretty much be treated as if there were no differences. So that goes for internal organs, that goes for anything on the skin, under the skin that is visible. And the only aspects that were really seen as potentially different were the things covered by the bikini. Well, turned out that wasn't a great idea, and I will try to guide you a little bit through why that wasn't the greatest of ideas. Before I do that, just briefly about the terminology we're working with in the field of sex and gender sensitive healthcare. It's not necessarily the same in all fields of research. So if you look at the investigation of gender in other fields, you might find a different use of the terminology, you might find different choices, and depending at where you look historically, also a division between sex and gender, or actually a use of just the terminology of one or the other might be possible. So this is kind of the status quo in healthcare at the moment, which might change over time. So the way we approach it right now is these are sex aspects. So the things that we associate with biology, really with genes, gonads, and genitalia. So everything that is defined by either our genetics, or that can be related to hormonal influences, or that is related to differences in anatomy or physiology, is investigated under the term of sex differences. Everything else around it, so everything you're seeing here, is pretty much gender and its different dimensions. And the way we have been approaching this in the last 5 to 10 years or so was trying to disentangle the different layers that you have in order to make it actionable in healthcare, because we were trying to find ways to transform a concept that came from the social sciences into something that worked for our methodology in healthcare, which is mostly quantitative and many times it's binary. So the different dimensions you can investigate are, first of all, identity. So identity is really who you are, what you feel like, and who do you feel you are like, what you are, like a woman, a man, a non-binary person, a trans person, a gender, whatever. It's something that you feel deep inside yourself. And most importantly for us as healthcare professionals, the only way to really know your identity is actually ask you. So it sounds very simple, but it is something that I need to repeat to my students every time. It's really something where you, or your patient in that case, is the expert about, and you cannot define from outside. The second layer is role, which is what's projected onto us from outside. So what does society expect from us as a woman, as a man, as a non-binary person in the year 2022, wherever you're living, in an urban area, in a rural area? So which kind of actions, which kind of attitudes are expected of you? And what happens if you don't conform with those? And that, of course, is relevant, for example, towards your interaction with the healthcare system. So when are you going to the doctor? What kind of symptoms are you describing to the doctor? Do you feel comfortable talking about these symptoms? And what is expected of you from the doctor, for example? Then we have this layer, which is relationships, which, to put it in very simple terms, is the interaction between these two. So between your subjective identity and really the roles are projected onto you, and how those two things come together when you negotiate anything in the private or in the public space with another person or other persons. And that can go from the private space. So if there is any care work to be done, so children or relatives are sick, who's going to stay home with them? To the professional arena. If you have to negotiate your salary, how are you going to go about that? And how do people react to you negotiating this if you are a woman or a man or a non-binary person? So it can really go at different layers. And then the highest layer that we can put on top of that is institutionalized gender, which is really what society and law kind of places onto us in terms of gendered expectations that are baked into the way our laws and our societies are actually built up. And it also goes, of course, within organizations. So, for example, what is a CEO supposed to look like? What is a professor supposed to look like? And what happens if you don't conform to those expectations? So these are just 4 of the potential layers you can be investigating. There are others that you could add on to this, but this at least gives us the opportunity to kind of disentangle different dimensions when we try to measure this in medicine. But now let's move back from a somewhat theoretical background to a more practical approach. So when you think about a heart attack, this is what we were taught a heart attack looks like. So that you have pain in your chest, which irradiates to your left arm, and that is pretty much the typical symptom. Now, over the last decades, we have realized that yes, this is the most common symptom, but it is not the most common symptom for everybody. It is the most common symptom most likely for this patient, but if you are a young woman, it might not be the symptom you're feeling. You might actually have quite different symptoms. So this has, fortunately, through a lot of advocacy work, reached more and more of the general population, sometimes being more easily accepted than in the medical professional field itself. And we've seen this shift and a definitely growing attention towards the cardiovascular risks for women. Now, however, if you do Google heart attack, this is what you get. So of all the images you'll find here, if you take the first 100, 4 of these images will be women. It depends a little bit on where you are and when you do this, but in principle, that's what I found. And well, funnily enough, 2 of these women were the same. So 1 image was there twice. But that's just to say that in our collective subconscious, we somehow are opening up towards realizing that, yes, there might be differences and not everybody, not even all men might have these typical symptoms, but somehow the images we have are still gendered, are still perpetuating some of these stereotypes, which of course is not ideal. And why is that not ideal? Because clinical presentation can vary. It can vary depending on who you are, depending on how old you are, depending on whether your body is female or male in its biology, depending on gendered aspects and expectations that I said before. And some examples that are quite striking is that, for example, asthma, which we kind of all know because most of us know somebody who has asthma and might have even witnessed an asthma attack. When we think about the typical wheezing, the typical sounds that a person makes when they have an acute situation with asthma is much more frequent in boys, while little girls much more often present with cough, which mostly presents at night. So the typical symptomatology here might be slightly different depending on whether you're a girl or a boy. When it comes to Alzheimer's disease, we see that there are quite some differences in the presentation. So when we think about emotional aspects of it and behavioral changes, these are more typical for women. When we think about physical impairment, actually disabilities in movement and apathy, these are more typical in men. And one might wonder that since we mostly associate Alzheimer's with behavioral changes, emotional problems, and memory loss, if this might contribute to differences that we see in diagnosis of Alzheimer's. The same thing goes for autoimmune diseases. So most autoimmune diseases are more common in women than in men. So that's an epidemiological fact. There are a few exceptions, but really most autoimmune conditions are more common in women. Which leads to the fact that the symptoms we ask about in our patients are mostly modeled on a female patient. And in this case, the typical symptoms you'll be asking about for lupus erythematosus, which is not very common, but still present in the population autoimmune disease. The things you'll be asking about is malar rash, which is really a redding of your cheeks, Raynaud's phenomenon, which is discoloration of your fingertips, depending on temperature, for example, and changes in the blood. So these two are things you can see. So these are things that can be seen from outside. And they are quite common in women who have lupus. They are very rare in men who have lupus. So overall, lupus is much more common in women. But the men that do have lupus, a lot of times when they are diagnosed, actually do have internal organ damage. So they have, in fact, inflammation of the internal organs, and a lot of times already kidney disease by the time they're diagnosed, which means that the disease is already much more advanced. So really, depending on the image that we have of a disease, our likelihood of diagnosing it and maybe of diagnosing it somewhat later is really impaired by that. This doesn't just go when it comes to symptomatology. The same thing we really see at the level of diagnosis and management. So one example that is quite well known is bladder cancer. Bladder cancer is notoriously diagnosed later in women. This is improving a bit because attention to the topic is rising, but we know that a lot of times when women present at the doctor's office and say that they have seen blood in their urine, the first thing we think about is really a urinary tract infection, which makes sense because that's the most likely thing. However, if this persists and you're not responding to antibiotics, for example, there might be other things that need to be investigated. And we know that a lot of times the diagnosis of bladder cancer is actually done in a quite delayed fashion because we thought that the person had a urinary tract infection. The typical, and I say here in quotation marks, symptoms of depression, such as the sadness, the tiredness, the lack of energy, are much more common in women than in men. While in men we see more other symptoms, for example, outbursts of aggression, abuse of drugs and alcohol, and so forth, and much less of this typical tiredness and lack of energy that we associate with depression. Another quite striking example is osteoporosis. So in our collective perception, osteoporosis is a disease of postmenopausal women. So we screen postmenopausal women for the disease. We don't screen postmenopausal men we don't screen men of the same age in most cases. And so that leads to the fact that the 30 to even 40%, depending on the statistics, of men over the age of 70 that do have osteoporosis will not be diagnosed until they might have a fracture of a bone, when we find out that the bone is not regrowing as it should because there is underlying osteoporosis. And then this is a quite striking study from Israel, which was about multiple sclerosis. Multiple sclerosis is an autoimmune disease, which is notoriously difficult to diagnose because a lot of times you have symptoms and then for quite some time you might not have any symptoms, sometimes for a decade. Hence, it is quite difficult to pair these symptoms with the diagnosis. And if you ask patients who have multiple sclerosis which kind of specialists they have met before the diagnosis was actually clear, women will be much more likely to tell you that they've seen a psychiatrist, and men will be much more likely to tell you that they've seen an orthopedic surgeon, because in one case we thought it was more of a psychological, psychiatric condition, and in other cases we might have thought it's more of a functional condition. Well, and then of course there's the layer of therapy, and this is gaining a bit more attention. It has gained some attention in the wake of the COVID-19 research as well. These are drugs that have been pulled from the market in the late 90s to early 2000s by the FDA in the United States. And what you see is that of these 10 drugs, 8 actually had much more significant side effects in women, sometimes more deadly side effects in women. And what we can point out here is this, the torsade de pointe. The torsade de pointe is a very rare arrhythmia, which doesn't really happen often spontaneously, but it's a well-known side effect of certain types of medications that alter the cardiac rhythm, so the way the heart beats. And the patients who had this side effect were almost exclusively women. Unfortunately, this was quite a striking finding that did affect, as I said, women much more than men. Could this have been prevented? Well, possibly, at least in part, because until the early 90s, women had been excluded from clinical trials with the rationale of protecting their potential children from unwanted side effects. So women participating in trials could potentially have gotten pregnant. And with this in mind, the decision was, okay, we exclude them altogether because by the time they enroll, they might be pregnant, they might not know yet at that moment, and we might be giving them medication that could harm either themselves or, in this case, more importantly, the unborn baby they might be carrying. Now, so this was born out of good intentions, but had quite bad consequences, because what happened was that women were excluded from the trials, the pharmaceuticals were tested, and then they were given to the entirety of the population. And then we found out about certain side effects once this was given to a larger population without even knowing that women could be affected. So overall, this might not have been the greatest of idea, which is also the reason why since then women are included in clinical trials, and we're becoming better and better at actually including them in appropriate numbers to even be able to do statistics that will tell us if there are any risks. Now, how is it with technology and with design innovations? How far do sex and gender play a role here? Well, there's pretty much two approaches that we're seeing mostly. One is pink and pinker. So what you're seeing here is the Fitbit throughout the years, and you can see we went from a very bright and shiny pink to a somewhat more subdued pastel pink, but it's still pink. The Fitbit became bigger, but it didn't become very much different in terms of color. So that was one option, the pink it and shrink it if you want. And the other option we're seeing is this. So this is one picture of the femtech market where all things women should be done. Unfortunately, the femtech market in its broadest sense is still mostly limited to what I name here breasts, ovaries, and vaginas. It's really a market that rotates mostly around fertility. Wanting to get pregnant, not being able to get pregnant, menstruation trackers, and that's pretty much, and then, well, if you got pregnant, nursing care and pelvic health care if needed. Now, it's of course important to look at that. So it's great that we do have companies that look into that, but in one way or another, the feeling I get is still this: that the same bikini that we saw on the human body, we're seeing here again for multiple reasons. And we're actually leaving out a lot of the cross-cutting issues that I just showed you, where normal diseases, so diseases that affect anything that doesn't have anything to do with breast, ovaries, or vaginas, are still displaying differences. And these should be included in all of these other products and all of these other apps and innovations that we have that deal with normal diseases that are unrelated to gynecology in this case. So these are the two things we're seeing. Let's look a bit at aspects that we should be considering. I have a few questions that you might want to consider. We might want to consider in developing your products. So in the content part, the first question that you should be asking is, if you do anything in that field, is what are you actually measuring? And it seems simple, but it's really not. Because if we look at what we've been doing in the healthcare field for decades, we really conflated sex and gender and used one to define the other. We have a lot of studies on cells or studies on mice that are running under the title of gender differences in whatever molecule. So it is really important for us as a growing approach or discipline, if you want, and for the people who are doing this to be precise about what we're measuring. What is it that you're actually doing? Because at that point, you can define what the actionable next steps are. And it's also in engaging with other stakeholders, especially in the healthcare field, where gender is still a concept that is not well defined and well known to everybody. You need to be able to clearly say what it is you're measuring. And at that point, you might actually be able to engage people who in principle might not have been interested before. So the definition of what you're measuring is essential. The second point is, does your product recognize your user? So this is work from Joy Buolamwini from MIT, and you might have seen this before. What Joy did was looking into commercial facial recognition algorithms and how well they performed with diverse population. So Joy herself is a Black woman who tried out one of these commercial algorithms and wasn't recognized by the algorithm. Then she put on a white mask and the algorithm recognized her. So of course she realized something was wrong with this technology and something was deeply and inherently biased. So what was done afterwards, what she did was using some of these commercially available facial recognition algorithms and presented them with a broad panel of different people, women and men of different skin colors. Some images are more grainy, some are more defined, and she used those to see how the algorithms would perform. And basically, to put it in very blunt terms, I would say some are more racist and some are more misogynist, but we can say that in more nice terms. Some are really good, well, all of them are really good at recognizing light males. So men with light skin are here, and you see most of the algorithms do no mistakes whatsoever in recognizing them. Some do okay in recognizing women with light skin. Some don't really that much. Some do pretty good at recognizing men, even with dark skin, but others don't. And if you are a woman with dark skin, your odds of not being recognized are the highest. So what we're seeing in all these algorithms is that they are basically performing differently, and not necessarily because upon their design somebody wanted them to perform differently, but just because they have been trained on white males. And if you do train an algorithm on a certain type of population, of course, it's really good at recognizing that. But then if you try to use it on a population that looks really different, it might not be performing as well as we're seeing here. So the essential question here is, does your product really recognize your user? And your users are a diverse population. They're probably not just white males. The third question is, will your user be able to use your product? So this is a colleague of mine at the time in Berlin. This is a woman, and this is one of the devices you're using during a surgery, which you sometimes have to hold in your hand for hours. This was, of course, not designed for the average woman's hand, as were most of the cell phones we have today. So the question is, the device that you've been designing, does that work? Well, for women and possibly also for men that don't have giant hands, because not everybody comes equipped with those. And so the question is, who has been testing your product, and does it work for everybody? Or do you want to try that on a diverse group of individuals? And quite frankly, sometimes adapting it for women might open up an entire new market of men, as I said, that don't have giant hands either. The fourth question, and this is relevant especially for gender, how do you guarantee the safety of your user? So especially if you ask about gender identity, and if you ask maybe also about sexual orientation, I just remind you that not all countries handle that in the same way. So if your app, for example, is asking about gender identity, consider the fact that this data could potentially be deadly in certain regions of the world. So data safety, if you embark in becoming more inclusive and asking your users about their identity, potentially about their sexual orientation, can become very seriously, potentially dangerous data. So you need to be very sure about how you're storing this data, how you make it accessible and how you protect your users in order to not expose them to any potential harm. And the last one, and I think that's not exactly one that we should ignore, is will your user actually survive your product? And so this is a chatbot that has been developed several years ago, and it basically tells you which potential disease you could be having based on symptoms that you're describing. So in this case, we have a 56-year-old person that smokes 10 cigarettes a day, that has had painful left arm for the last hour, and possibly chest pain, and now feels sweaty and sick. So I showed you some pictures before. You probably have some ideas about what this person could be having, and now this is what the chatbot suggests. So if you're a man, you might be having a pericarditis, which is an inflammation of the heart. This is usually treated in the emergency department. Second option is you have unstable angina, also something you should be going to the emergency department for. Number 3 is you have a gastritis, so stomach flu. This is usually something where you can go to your GP the next day. You might be having a panic attack, so you can stay at home, breathe into a paper bag. And number 5 is you could be having a heart attack, which is also treated in the emergency department. Now, I would probably assume that most people seeing these things will take a trip to the emergency department because you want to rule out those things that might kill you. Now, if you're a woman, these are the options that the chatbot gives you. And number 1 is you're having a panic attack. So breathe, stay at home, you'll be fine. And number 2 is you might be having depression, which you probably will have once you found out that you had a heart attack and didn't go to the emergency department. Now, fortunately for us, this chatbot was not released to the market, and you can find some of these other suggestions that it did if you use the hashtag #DeathByChatbot on Twitter, and you might find some of those. But what does it do? Again, as I said with the data about the facial recognition algorithms, it was probably not programmed to kill women, or at least I assume it wasn't. But it was trained on historical data. And so if we use historical data where women had been misdiagnosed based on the symptomatology, what the chatbot will be doing is it will be reproducing this data, and it will be reproducing those suggestions because it cannot decide whether they were good or bad. And so that's the thing with data. You need to make sure where your research is coming from and which kind of biases are inside the data you're using. 2 more points. In the conclusion, it's about gender in context. So we just talked about the content part. The context part is this. So number 1 is, have you ever talked to your users? You probably know the guys from Silicon Valley. Does your team, whenever you present some kind of innovation, you develop some kind of innovation, or you're a startup, or you're just working in an average team, do you actually represent different perspectives? Is the voice of your users present in that team? How do you bring that in? Does anybody in your team actually think like your users? Or if they don't, how can you bring those user voices in? So that's an essential aspect about who is represented. And the second part is, do funders actually realize that your user exists? And as I showed you before, the femtech market is a bit of a bikini market, which might also be connected to this, because as you're seeing, female founders get a lot less money, and a lot of times are actually forced to resort to a field that male innovators were not interested in. So I just showed you this group, and I cannot really see this group in coming up with a period app. So from that perspective, it's also a question of, why do we see a femtech market that mostly deals with certain issues, and are these the crumbs that have been left over? And in how far is this actually regulated by the market? Now, my conclusions. So what should you take with you in designing possibly a sex and gender sensitive innovation or tool or anything along those lines? Well, first of all, as I said, look beyond the bikini. The bikini was not such a great idea, at least not in this context. Then consider the sex and gender and diversity in your team. As I said, does your team have the expertise in whatever innovation you're developing, that goes for healthcare or for any other field, to actually bring the user perspective in? Consider sex and gender differences at every step of the process. I showed you in healthcare, we really see this at the symptoms level. We see this at the diagnosis level. We see this at the therapy level. We see this in who is accessing healthcare. So it really goes through the whole process, and you need to consider that. Number 4 is talk to experts. You don't need to know everything about this. Of course, you're taking this course and you will know a lot more about it. But if you're developing innovations, it might be important to keep people on board who can help you along with that. Evaluate the science that backs your product for sex and gender sensitivity. So as I said before, if the data is biased, you might have a biased product simply because in the past we have had biased data, and sometimes we're still developing those. So in how far is the data you're using for whatever you're developing, is that actually taking sex and gender into consideration? The last one is really evaluate the market that you're trying to bring this product in. Is the market actually open for sex and gender? Do you need to make the market aware of these sex and gender aspects before you're actually able to place your product, simply because people don't realize that it actually matters? So do you need to incorporate that in your pitches, or do you need to incorporate that in a somewhat broader perspective? And of course, the last one is spread the word. So what I just told you might be relevant for you, and it might be worthwhile spreading because it could be worthwhile to know for other people as well. And with that, I thank you very much for your attention. And of course, please feel free to be in touch if you have any questions. And I hope you will take some of these messages home and put them in your practice. Thank you very much. Well, it is. I mean, we're kind of at the crossroads of moving towards a more intersectional perspective while still being held back by the statistical approach on how to do that. I would put it like this. So there is, of course, growing attention towards the fact that looking at, for example, differences between female and male bodies in medicine at a biological level, it's just a first step. And really, first of all, of course, you could say at the biological level, you need to consider intersex individuals, but that's really just a first step. Once we start taking gender into this, it becomes much more diverse and much more complex because, of course, not all women are the same, not all men are the same, and not all non-binary people are the same. So to really capture the details of people's identities, and especially if you want to develop interventions for specific groups in the population, you need to do this in a much more specific and graduated fashion. Is this possible in quantitative work? Well, it's complex because, of course, the smaller the groups become, because you're adding more and more layers of diversity that intersect with each other, the more complex the analysis becomes, or sometimes you're not able to do it anymore. So that's really a choice between having a very, very large population where you can have multiple subgroups and you can still do a proper analysis, or actually picking a specific subgroup and saying, okay, I'm only going to go with this group because here I can go in the details of what they actually need. In qualitative work, most of the time we do this pre-selection because we tend to not interview thousands and thousands of people. That would simply not be sustainable. So usually in our qualitative work, we tend to make this pre-selection and kind of pick a certain group of users, and still there you will find individual differences, but you're not going for representativeness of an entire population. You're just trying to represent perspectives and go in the depth of, why they might have certain healthcare needs. How can you address these healthcare needs? How do they describe it themselves? So in a way, it is really a balancing act between becoming more true to the reality of people's lived identities and needs, and on the other hand, trying to balance that with what is methodologically possible in healthcare research. I think it's a step in a way, and it can be used as a first example on how to do this. I mean, the interesting part that we're seeing in the field of sex and gender sensitive medicine is that we do have two aspects, which are biological sex and gender, that correlate to a certain degree, but only to a certain degree. And they also have two very, very distinct elements. And you don't really see that for a lot of other categories of diversity. So it's, if you look at social aspects, it's not like you have a biological correlate. Or if you look at racialized aspects, it's really a social construct. It's not something that we measure in biology. So in a way, the fact of sex and gender sensitive medicine allows you to approach this in a somewhat more holistic way. But it is really a first step. And if we consider that gender is developed and is performed in combination with different layers of identity, with different aspects of identity, it also becomes clear that you will not be able to capture it fully if you only focus on that. Although, looking at it from a perspective of medicine, it's already a lot if we have disaggregated data now. So we also need to make sure that we stay connected with where the research community is, and make sure that the research community opens up more and more towards the topic, and then try to open the topic up more, rather than confronting people with the need for a fully intersectional approach if they haven't been looking at disaggregated data by sex until 2 days ago. So I think it's also a process where we need to walk with the community that we're encountering.